So let me just introduce myself real quickly. I don't think I ever got a chance to, but my name is Christian Horn. I'm one of the hepatologists along with Dr. Hallweg at BAMC. I'm currently the chief of hepatology at BAMC, and you can see that we've had a couple of chief of hepatologies here from BAMC already. I did my undergraduate at UC Davis in California, then I went all the way across the country to Eastern Virginia Medical School to do my medical school. Then I went back over to the West Coast where I did my internal medicine residency up at Madigan Army Medical Center, and now I'm down here in San Antonio where I did my fellowship in GI and hepatology, and I stayed on staff after that. So that's just a little bit behind me, but if you've never heard me talk, which is the majority of the people in this room, I move around, I talk fast, so please keep up if you can. Well, there'll be time for questions in the past, or after the presentation. But there's a lot to cover here, so let's just dive into it. I have no financial disclosures. This is what we're going to talk about. We're going to hit the three big genetic causes of liver disease. That's going to be alpha-1 antitrypsin, hemochromatosis, and Wilson disease. And we'll talk about a little bit of genetics, presentation, all that kind of stuff, okay? Starting with alpha-1 antitrypsin, we're going to just kind of go in alphabetical order. So this is a problem in the alpha-1 antitrypsin protein, okay? That protein is a serine protease in the group A, class 1, member 1, excuse me. So you get this name called serpina, or serpina-1, serpin A1. So it's a serine protease inhibitor. What does that mean? It inhibits proteases. Proteases are enzymes that eat other enzymes. So if you inhibit that, then you inhibit the ability to eat other enzymes, okay? The main target of this is the serine, protease elastase, okay? So if you're inhibiting this protein, then you can't eat up elastic tissue, okay? But if you're not inhibiting this protein, then you have unopposed elastic tissue destruction, okay? Just keep that in mind. This provides 90% of the anti-protease activity in the entire serum, okay, in the entire body. So it's a really important protein. Majority of it is synthesized in the liver, about 80% of it. And it's transmitted in an autosomal codominant fashion, which means you have two different alleles, and they code for proteins, and not one of them is dominant over the other one. Basically, they're going to kind of go together, okay? Major alleles that you're going to have is the M allele, which is your normal allele, the S allele, and then the Z allele, okay? When we're talking about these M, S, and Zs, these are the proteins that form in the serum, okay? We're not talking about the genes. These are the proteins, the M protein, S protein, Z protein. So when we're doing diagnostic testing, we're going to test the phenotype of that, which is the expression of the gene, which is that protein, okay? So it's not a genotype, we're checking phenotype. The majority of the combinations of these are going to be some sort of MS-Z combinations. There are more rare manifestations of this, like the rare null phenotypes, but the majority are M, S, and Z. So with the Z phenotype, you're going to have an abnormal folding of this protein, okay? When that happens, this is going to cause an unstable protein. It doesn't like to be by itself, this abnormally folded protein, so it tends to polymerize, okay? So you get all of these abnormal proteins that are conglomerated together, and it gets stuck within the hepatocytes, and then it can't be excreted into the serum, okay? It gets actually stuck in the endoplasmic reticulum, and this is the inciting event for liver disease. It's kind of like a storage disorder syndrome, okay? So basically, you can't secrete the protein normally into the serum, gets caught in here, that's what causes liver disease. This almost always happens exclusively with the ZZ phenotype. So both of them are going to be abnormal. You can probably see some degree of this with the other phenotypes, the SZ phenotypes, but almost always is going to be the ZZ phenotypes. Real quickly on the null allele, this is one that I've seen on board questions before. Null allele means you don't have any protein. So what does that mean? Well, you don't have any liver disease because there's no accumulation of the protein in the liver, but you have the disease outside of the liver because you don't have that anti-protease activity, okay? So you can still get lung damage, connective tissue damage, et cetera. This is the epidemiology. I won't belabor this too much, but more common in Western countries, probably a little bit some prevalence in Eastern Europe, but you can see in Africa and the Middle East, it's not as common. So mostly Western countries is where this is going to be. When patients present with this condition, it's going to be all over the spectrum of liver disease. So it can be anywhere from asymptomatic presentation to mild elevations of the liver enzymes, all the way to complications of cirrhosis with portal hypertension, et cetera, et cetera. Uniquely with this one is you get this prolonged jaundice within the neonatal period. So this is, goes along with that neonatal hepatitis syndrome. So we all know that when kids are born, the bilirubin is really high, and that usually peters out over a period of time. With these patients, sometimes they can have that prolonged jaundice in the neonatal period, and so that's kind of a clue towards that this might be alpha-1 antitrypsin deficiency. Because this happens, or this starts to occur at such a young age, the timing of transplant is going to be at a younger age. So usually 34 to 54 is going to be the time that these patients are going to need transplant. Outside of the liver, there's a number of different organs that tend to get affected. The most common one is the lung. Once again, this is going to be with the ZZ phenotype, or maybe the SZ phenotype, or maybe that null phenotype that I was talking about, okay? And because you lose that pancreatic elastase inhibition, that goes unopposed, and you get eaten, you start to eat up the elastic tissue within the pulmonary interstitium, and that causes early COPD, okay? So this is a lack of that protein in the serum that causes the lung disease. Other rare forms of this, and the boards love rare manifestations of rare diseases, so this is important to know. Paniculitis, so you get these kind of nodules or these painful inflammatory lesions either in the abdomen or in the pelvic region. It can cause scarring, it can cause fistulas, so that's one of those rare manifestations. And then vasculitis as well, particularly affecting the sinuses, the lungs, or the kidneys, okay? Rare manifestations of rare diseases, the board is gonna ask about that. Gold standard is to do the phenotype testing that I talked about, okay? But you usually start with doing a quantification of the amount of the protein within the blood. So you order your alpha-1 antitrypsin level. If that's below 100, that's gonna make me go and do the phenotype testing, okay? Most of the time, if you're looking at a level of like 80s, 70s, they're gonna have one mutation, they're not gonna have both of them. If you're down in like the 20s, that's when you really should be worried about someone who has the ZZ phenotype and they have full-blown disease expression. Once you have that low level, then you do the phenotype, figure out what the phenotype is, you have your diagnosis, okay? Not gold standard, but liver biopsy is also a possible test that you can do. The findings are non-specific though. You can get some inflammation, steatosis, fibrosis, cirrhosis, et cetera. But really the key thing that's gonna be tested on that you might see on this biopsy is these PAS positive diastase resistant globules, typically in the periportal area, okay? That is board fodder right there, so remember that one in particular. Unfortunately, there's no treatment for this. So the best thing that we can do is support people, try to treat any symptoms that they come up with. If they have lung manifestations, you can give them purified alpha-1 antitrypsin protein, so that is something you can do for the lungs. A lot of these people, if they have some sort of manifestation of this, I'll send them over to pulmonology so they can do PFT testing to see if they have developed any lung manifestations. But there's not a lot that we can do for the liver disease. We're gonna support them until the time where they're gonna need a transplant, okay? So once they start to develop symptoms of cirrhosis, then we can start to treat those symptoms, ascites, variceal hemorrhage, et cetera. But unfortunately, there's not much more that we can do for this. So once I get to the liver failure and decompensation stage, then we're gonna refer them for transplants. Okay, moving along to hemochromatosis, one of my favorite conditions to diagnose and treat because it's very satisfying, I think, in how you make the diagnosis. So hereditary hemochromatosis, or hemochromatosis itself, is a condition of spontaneous iron accumulation within the body. Why is this a problem? Well, iron, when it's not bound, if you have too much iron, it's very reactive, okay? Especially in an aerobic environment. And it causes damage all throughout the body. It could damage other organs, it could damage blood vessels, it could damage cells, subcellular structures. So it causes problems all throughout the body. So if you have too much iron, you're gonna have these other problems showing up. The HFE mutation is the most common mutation that we're going to see in hemochromatosis, but is also the single most common mutation in Caucasians, okay? So it's going to be pretty common in that. 85 to 90% of people who have hereditary hemochromatosis is going to be HFE mutation, specifically the C282Y mutation, okay? Outside of that mutation, there's two other mutations in the HFE gene. You have the H63D and the S65C, okay? All three of these mutations are in the HFE protein. And I'm harping on this point because this is one form of hemochromatosis and there's other forms of hemochromatosis. Incidence and prevalence is gonna depend on what the mutation is, okay? So a little bit about iron pathology or pathophysiology. Physiology, iron gets pulled up from the intestines, it goes into the enterocytes, and it's pumped into the circulation through this protein called ferroportin. This is important. Once the iron is in the bloodstream, it gets bound up by the protein transferrin. We've all heard of transferrin. We know what transferrin saturation is. Transferrin transports the protein or the iron all around the blood. Goes to the bone marrow, forms red blood cells, goes to the macrophages where it's stored in the form of ferritin. We know that as well. And then if you're trying to get the ferritin out of macrophages, you also use ferroportin to pump that out. And with the assistance of this protein right here, which is ceruloplasmin, you convert the iron to transferrin, okay? So ferroportin and ceruloplasmin are both important in getting ferritin to transferrin. Now, looking at the liver over here, we can see the transferrin binds to the transferrin receptor. That causes production of this protein called hepcidin, and then hepcidin will go back and negatively inhibit ferroportin. That is your iron regulation in a nutshell, okay? So iron goes back, it's a classic negative feedback loop. Goes to the liver, creates hepcidin, which inhibits ferroportin. When we're looking at the liver specifically, what's happening? So I said there's multiple forms of hemochromatosis. This is where it's going to come into play. We have the HFE protein right there, which is a cofactor of the transferrin receptor, okay? So if that's out, then you lose your signal transduction. You have your HJV, which is hemojuvelin. This is a different pathway, but it's a signal transduction pathway to the formation of hepcidin. And then you have the transferrin receptor 2. HAMP right there, that is the gene for hepcidin. So mutations in any of these things that I've circled will cause hemochromatosis, okay? This is a nice summary that was in ACG guidelines for hemochromatosis that talks about the various forms of hemochromatosis. And there's 4 large categories. The first category is the HFE mutation. Once again, there's 3 mutations in HFE. There's the C2A2Y, there's the 863D, and the S65C. So you have type 1, 2, or type 1 A, B, and C hemochromatosis, all with the HFE protein. Type 2 is juvenile hemochromatosis, okay? This is a problem in the hemojuvelin protein or in the HAMP gene, okay? This is unique because what it's going to do is it's going to cause iron overload at a younger age, and it's going to cause extra hepatic manifestations in the pancreas, in the heart, in the brain, all that kind of stuff. So this is kind of a more aggressive version of hemochromatosis. Type 3 is a mutation in that transferrin 2 receptor. Type 4 is very unique. It's a mutation in that ferroportin protein itself, and there's 2 versions of it. But this is unique because it's the only form that's autosomal dominant. All the other ones are autosomal recessive, okay? Presentation, kind of like alpha-1 antitrypsin, is going to be variable. It's going to affect multiple organs throughout the body. In the liver, it's typically going to cause anywhere from asymptomatic to cirrhosis, depending on where you're at. For men, it tends to happen at a younger age. For women, older, postmenopausal, because women are protected from their menses, or with their menses, from hemochromatosis. Other things that could cause you to develop end-stage liver disease early with hemochromatosis is alcohol use, higher BMI. So anything else that would damage the liver would cause you to have more aggressive disease. Classically, if you have a ferritin over 1,000, that is a risk factor for cirrhosis at the time of presentation. Outside of the liver, extrahepatic manifestations, arthropathy or arthritis in the hands. So this is very classic board question. Second and third MCP joints. MCP is metacarpophalangeal joints, and it causes those hook-like osteophytes in those joints, okay? So second and third digits are going to be your index finger and your middle finger, those joints right there, those knuckles right there. For cardiac manifestations, this is a result of iron deposition within the heart. If you have iron deposition in the heart, you interfere with the conductive system within the cardiomyocytes. And so you're going to get conduction abnormalities, arrhythmias. You're going to get a restrictive cardiomyopathy, which results in heart failure. And it can actually cause carotid intima media thickness, increase carotid intima media thickness. That causes early coronary artery disease. So multiple manifestations of heart disease. Fortunately, it's not very common to happen. Endocrine abnormalities, so deposition in the pancreas will cause diabetes. Deposition in the pituitary can cause hypothyroidism or can cause hypogonadotropic hypogonadism. And then osteoporosis is also more common. Deposition of iron within the skin will stimulate the melanocytes, and that causes that bronzing of the skin that we see with hemochromatosis. And so this is where we get the moniker bronze diabetes, is from deposition in different organs. Typically, this occurs on sun-exposed areas, so extensor surfaces of the arms, legs, face, etc. Other things that you're going to see is fatigue, very classic. You're going to have increased risk for infections, specifically Vibrio vulnificans, and then rarely you might see some movement disorders. This is my favorite algorithm on how to diagnose hemochromatosis, but there's multiple different algorithms on how to do this. I think this one makes the most sense to me, so this is what I followed. This is what I teach all my fellows. This is the 2022 EASL, European Association for the Study of Liver Disease guidelines. You start by finding the people that you want to screen, and those are people who have family history, or they have symptoms, elevated liver enzymes, something like that. And you screen them with a ferritin level and an iron transferrin saturation. You need both an elevated ferritin and a transferrin saturation greater than 45 before you start going down the hemochromatosis pathway. If the transferrin saturation is less than 45, send back to the PCM and say, please evaluate for secondary causes of hemochromatosis, such as viruses, NAFLD-NASH, inflammatory conditions, all that kind of stuff. Just because the ferritin's high does not mean it's hemochromatosis, okay? Once you have an elevated transferrin and ferritin, then you're going to do the HFE mutation analysis. And this is because that's the most common form of this, okay? If you have C2A2Y homozygous hemochromatosis, you're done. You've made the diagnosis, you can send them to treatment. If you have any other version of this, or if that HFE mutation is negative, then you're going to look for iron overload anywhere within the body, okay? So this includes getting an MRI of the liver, or getting a liver biopsy, looking at the heart, looking at the pancreas, all that kind of stuff. So if there's evidence of iron deposition anywhere in the body, specifically the liver, because that's what we care about, then you're going to look for those other rarer forms of hemochromatosis, the juvenile hemochromatosis, the transferrin 2 receptor hemochromatosis, or the ferroportin disease, okay? So that's when you're going to send off a genetic analysis for those rare forms of hemochromatosis. So liver biopsy, I touched about this. This is occurring less frequently because we have non-invasive ways to assess for fibrosis and all that kind of stuff. Classically, if someone came in with C2A2Y hemochromatosis with a ferritin over 1,000, the board question is going to be send them for a liver biopsy, because about 40% of those people are going to have cirrhosis on presentation, okay? So we don't do that as much anymore because we can detect cirrhosis with MRE, with FibroScan, all that kind of stuff, right? If you do biopsy, though, you're going to do the Pearl's Prussian blue stain. You're going to see iron deposition within the hepatocytes, okay? If the iron deposition is inside the Kupffer cells, that's secondary iron overload, okay, predominantly. If you have mostly iron deposition within the hepatocytes and then some iron in the Kupffer cells as well, that's also hemochromatosis. It's because iron is spilled out of the hepatocytes and the Kupffer cells go and eat up that iron, okay? And then you can send off a portion of it to evaluate for hepatic iron concentration as well. MRI is now kind of like my go-to next step before I do a biopsy, because you can use a T2 weighted MRI to see is there iron within the liver, okay? This might be a little bit better to rule out iron overload in the liver, but it's good to kind of pick it up as well, okay? And so it uses basically the fact that iron looks darker in the liver, and so you're going to have a darker image of the liver when you're doing this. One key pearl with this is if the radiologists comment on iron deposition in the spleen, or the spleen looks like it has iron deposition, that's more common in secondary hemochromatosis, because what's in the spleen? Macrophages, right? So secondary iron overload is going to be elevated ferritin. Ferritin stored in the macrophages, spleen hangs out, or macrophages hang out in the spleen, okay? So this is probably my go-to step if I'm looking for iron overload, is doing the MRI of the liver. When do we start treatment? So C2A2Y homozygous hemochromatosis, we're going to start treatment for men if the ferritin's over 300, for women if the ferritin's over 200. And you're going to start off by doing an induction amount of phlebotomy, which means you're going to be doing a whole bunch of it up front. And then once you get their ferritin to goal, about 50 to 100 of the ferritin, then you're going to do maintenance. And most of the people on maintenance only need to have a couple of sessions a year, basically. As long as they tolerate the phlebotomy, they don't get too anemic, you can keep on phlebotomizing them as much as you want, okay? Other therapies that are out there that we don't use very often, erythrocytophoresis. So these are people who have other issues, like if they have thrombocytopenia and you don't want to pull out whole blood, you can selectively pull out red blood cells. Problem with this also is anemia. It doesn't fix that problem. So if someone's anemic and you're trying to phlebotomize them, or do erythrocytophoresis, it's not going to work. In that situation, you probably have to reach to chelation therapy, which terrible, it's not my favorite. There's side effects from it, it's expensive, it's not very effective, but if that's the only option, that's the only option. Other things to keep in mind is vitamin C will cause increased iron absorption, so you want to tell these patients to avoid vitamin C. You want to tell them to avoid raw shellfish because that increases the risk for Vibrio infection, and then obviously avoid excess alcohol. All right, Wilson disease. I think I'm doing okay on time. So Wilson disease. Please note, this is Wilson disease, not Wilson's disease. It's not possessive. So Wilson disease is a problem with hereditary copper overload, okay? So there's a theme here. They're all overload syndromes, right? What happens in this situation is copper gets deposited within the liver because you can't excrete the copper out of the liver. Those hepatocytes eventually rupture because it exceeds their storage capacity, and that copper gets to go and deposit wherever the heck it wants in the rest of the body, okay? The problem with this was first identified in '93 in the metal transporting P-type ATPase. So basically what this means is this protein usually transports copper across organelle membranes. And so this protein is involved in incorporating copper into ceruloplasmin, and it's also involved in excreting copper out of the hepatocyte. So when you don't have this protein functioning appropriately, you don't have incorporation of copper into ceruloplasmin, and you can't excrete the copper out of the hepatocytes, okay? So this is a quick overview of how copper moves throughout the body. It gets picked up within the intestines, goes to the liver, gets picked up in the liver, incorporated into enzymes within the liver, or incorporated into ceruloplasmin, or it gets excreted out into the cell, or out into the bile, okay? Specifically inside the liver, you see copper gets picked up, and it's either incorporated into this superoxide dismutase, which is an antioxidant. It gets incorporated into mitochondrial enzymes, or it gets transported into the trans-Golgi apparatus, which is where it gets incorporated into ceruloplasmin, okay? You can see this protein right here, the ATP7B, or yeah, that protein, is the abnormal protein in Wilson disease, okay? So problems in that ATP7B protein means you can't push the copper into the trans-Golgi apparatus, and it never has the opportunity to be incorporated into ceruloplasmin. A little bit about nomenclature on ceruloplasmin. Without copper in it, it's called apoceruloplasmin. With copper in it, it's called holoceruloplasmin. Now, other step in this process is the export of copper out of the cell. So that's done with ATP7B as well, and it's kind of a cofactor in this process. So a mutation there means you can't excrete copper into the bile, and that causes copper to build up within the hepatocytes. Majority of these patients are going to present young, okay? But just because someone's older doesn't mean they can't have Wilson disease. It happens, okay? Mostly it's going to be between, 3 and 55. 55 is actually higher than what we used to think it was, but we have seen it in people in their 60s, 70s, all that kind of stuff. They're going to have probably extrahepatic manifestations. So no talk on Wilson disease is complete without the eye pictures. So you have the Kaiser-Fleischer rings, you have the sunflower cataracts. Those are both possible manifestations in the eyes. You can get neurological manifestations. This could be behavioral, psychological issues, movement disorders, all that kind of stuff. And then you can have the hepatic manifestations as well. These are going to present, once again, along the whole spectrum of liver disease. So anywhere from isolated elevated liver enzymes to unexplained liver hepatitis to cirrhosis, complications from cirrhosis, et cetera. Things that are going to clue you into Wilson disease in particular would be movement disorders, neurological manifestations, depression, anxiety, schizophrenia, or family history of any of that kind of stuff. And then Fanconi syndrome. So this is kind of interesting. The way that I understand this is Fanconi syndrome is a problem from copper interfering with the kidneys. And so you develop the Fanconi syndrome, which causes you to have a low uric acid because you're losing the uric acid in the urine, but also you have a low alk phos because you lose the alk phos in the urine as well as a result of the Fanconi syndrome. So low uric acid, and then Coombs negative hemolytic anemia. That's also another classic board buzzword for this one. Acute liver failure is a unique presentation of Wilson disease. So we think of acute liver failure as someone who hasn't had any history of liver disease in the past, but it's unique in Wilson disease because they can actually have fibrosis, cirrhosis on biopsy and still present with acute liver failure. So that's something that's unique about this. Fortunately, it's very uncommon for that to happen. Only about 5% of people have it. most commonly, it's tripped off by something that happens within the liver. So either they get a flu, they have a drug reaction, or they stop taking their medications. That's very common for people to stop taking their medications. Other things that you're going to see, once again, things that are going to clue you in for the acute liver failure being a result of the Wilson's disease is going to be that Coombs negative hemolytic anemia. What happens when you have hemolytic anemia? You have hemoglobin that leaks out. What is hemoglobin degraded to? Bilirubin. So your bilirubin is going to go up, right? So that's going to lead to this weird ratio right here that a low alk phos from the Fanconi syndrome, a high T-bili from the anemia is going to cause that low alk phos to bilirubin ratio, less than 1 to 4, okay? So that's going to be very specific for Wilson's disease. Probably not going to see it very often, but very specific for Wilson's disease. And then that AST to ALT ratio of 2.2 to 1, or 2.2, greater than 2.2 is also going to go along with that. These patients can progress to liver failure and need transplant very rapidly, so make sure you're staying on the top of that. A couple of topics or a couple of ways that we diagnose this. Wilson's disease is hard to diagnose, and I was actually talking to Dr. Hallwig about this. This is one of our least favorite conditions to diagnose because of how much of a pain it is to diagnose. So you have your ceruloplasmin, so we know that goes down because we're not incorporating copper into the ceruloplasmin, so you have low levels of ceruloplasmin. Less than 20, suggestive of Wilson's disease. Less than 5 is highly suggestive of Wilson's disease. Once you have that, then you have to go to the 24-hour urinary copper levels. If that's high, then you have high levels of copper excretion, and this is because you're measuring basically indirectly the unbound copper in the serum, okay? Checking a full or a whole serum copper level isn't really good because it reflects both the bound and unbound, so we don't really check whole copper levels anymore. And then you can do genetic testing as well. Just really quickly on the 24-hour urinary copper, in people who are asymptomatic, usually we're going to see a low level of elevation in that, so greater than 40. If people are symptomatic, they're probably going to have a high level of excretion in the urine, so greater than 100 micrograms per 24 hours. Liver biopsy would be the next step in the algorithm. So you do the liver biopsy so you can get the amount of copper that's in the liver. So you're almost always going to send it off for dry weight of copper, okay? High levels of copper in the liver, obviously suggestive of Wilson's disease. So levels greater than 250 micrograms per gram of dry liver is highly suggestive of it. You can do special stains for iron as well. Unfortunately, most of the manifestations of Wilson's disease are going to be nonspecific, so you can see everything along the spectrum of fibrosis, inflammation, steatosis, all that kind of stuff. The one unique thing here, though, is the mitochondrial abnormalities that you might see. And so that might clue you in if you have like a scanning electron microscope, not a scanning, or if you have electron microscopes, you might be able to see some mitochondrial abnormalities. This is what you're going to see on liver biopsy and Wilson's disease. These are some special stains that highlight the copper, but you can see up here on the H&E stain, not very specific. It's just kind of like steatosis, some inflammation, all that kind of stuff. Mitochondria, we all know what the mitochondria are, the powerhouse of the cell. So we can see down here on this electron micrograph that you see that kind of dilation of the cristae within the mitochondria. All right. This is fresh out from the new 2022 or 2023 Wilson disease guidelines, okay? And there's 4 different pathways in here, and this is going to be in your handout, so I'm not going to go into detail about it. But largely, what you want to look at is, do they have liver disease? They're going to be one of these 2, A or B. Do they have neurological disease? They're going to be one of these 2. What is that, C or D? I can't. It's another A or B. Never mind. And then once you have that, you're going to go, do they have Kaiser-Fleischer rings or do they not have Kaiser-Fleischer rings? So using those 4 things, you're going to figure out what algorithm they're going to go down. And largely that algorithm is basically what I just explained to you. Ceruloplasmin first, 24-hour urinary copper. If that doesn't tell you what the diagnosis is, then you move to your liver biopsy with dry weights. If that doesn't give you the diagnosis, then you're going to go to your genetic testing, okay? There are rare situations where you might have to do further testing, but this is largely the pathway you're going to go down when you're diagnosing this, okay? And that's basically recapitulated in these different algorithms, and it's in your handout, so this would be too hard to cover in detail right now. Treatment for Wilson's disease is going to be either copper chelating therapies, or it's going to be zinc, which helps to excrete copper in the stool, okay? So your 2 copper chelating agents are going to be triantarene or depenicillamine. These are old medications. We used to use D-penicillamine as like the first-line therapy, but it has such significant side effects that we're really not using it as much anymore. Our go-to at this point is really triantarine if you're going to put people on therapy for this. About 10 to 20% of patients are going to have worsening neurological disease when you start chelation therapy. So just be aware of that. They're not going to get better overnight. Just like most diseases in the liver don't occur overnight, most diseases in the liver don't get fixed overnight. And so this is going to take some time for them to get better with Wilson disease. Okay? When you're treating them, you're going to monitor their 24-hour urinary copper excretion. Because these chelators cause you to lose copper in the urine, they're going to go up, right? And so what you want is high levels of that 24-hour urinary copper in these sort of situations. Up front, when you're doing the induction, it's going to be somewhere between that 1,000 to 2,000 range. And then once you've got them where you want them, once they're like responding to treatments, then you're going to go to a lower range, probably like 200 to 500 micrograms for 24 hours. Now, zinc is kind of the exact opposite. Zinc is binding copper within the intestines, and so it's being excreted into the stool. So it never gets into the body itself, right? So you're still measuring the 24-hour urinary copper in these patients, but you want that to be low, okay? Because that means that it's not getting into the blood, and Wilson's disease is getting better, okay? There's dosing that's in here as well, and there's some side effects from these. Like I said, D-penicillamine is not really our go-to first-line therapy anymore because of the side effect profile of it. I think this is the last slide that I have. So transplantation for Wilson disease is going to be based on your MELD score, if they have cirrhosis, or they're going to be listed as status 1A if they have acute liver failure. So as Dr. Petrosek had mentioned, acute liver failure is one of those things that you don't sit on. You transplant them as quickly as you can, or you get them to a transplant center as quickly as you can, okay? Status 1A for this acute liver failure basically means that they're expected to die within 7 days. And so what happens is they go to the top of the transplant list. They are listed like #1 priority, and they actually look for livers in a broader geographical range than they normally do, okay? And then obviously if they have cirrhosis, that's going to be their priority on the list is going to be based on what their MELD score is. And we've moved from MELD sodium to MELD 3.0 right now as the standard. Those are conclusions. I hate conclusion slides, so those are my references. And then we will move to the Q&A because we're already running behind. Thank you.